Our next topic in pathophysiology 2 is disorders relating to the urinary system. So that would include the kidneys, the tubes that come off the kidneys referred to as the ureters, the bladder, and then the urethra that comes off the bladder. Today, though, we're going to look at obstructions that exist in the urinary system, tumors that exist, as well as infections of the urinary tract. In order to best understand these disorders, I'm going to review some relevant normal anatomy of the urinary system, as well as the production and flow of urine. If we look at the kidney, as shown here, this is a frontal section. We can see this structure here called the nephron, and these exist all throughout this region of the kidney. There are up to 1 million in a kidney or more, and these are the functional units that actually will ultimately produce urine. They also allow for us to concentrate our urine. They allow for us to get rid of substances that we don't want, but also keep substances that we do want. And so the nephron, if we looked at it and zoomed in, this would be what it would look like without blood vessels attached to it, with the exception of these two guys here. And then this is both. So the nephron consists of two main components. We have Bowman's capsule, which is the capsule around it, and this vascular network called the glomerulus, this capillary network, and this is where substances are filtered. So what will happen is blood will move into the kidney, into smaller and smaller vessels down to the level of the nephron. That blood will enter through the glomerulus. We will filter out substances into this capsule around it, and it will move its way through the rest of the tubular system. So what we have here is the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct, which is shared with other nephrons. So this is all occurring through here. So if this is the collecting duct enlarged, this is also, say, the collecting duct here. So anything that ends up in the collecting duct is really destined to be, especially at that distal end, to be urine and to be excreted from the body. It's going to pour into these cups that are found just at the tip of this pyramid structure here. It's going to collect in this cup, and this cup is called a minor calyce. Calyce referring to cup, so it's like a small cup. Then it's going to join with the urine produced from other areas of the kidney into this larger cup called the major calyce. From here, urine is going to collect from all of the different structures now into this enlarged area called the renal pelvis. From here, it's going to move into the ureter, where it's going to, this is the ureter here, continue to travel down to where the bladder is. And the bladder is really storage until you're ready to eliminate through the process of what's called micturition, which is the proper term for urination, where it exits through the urethra. But remember, as substances, that's called filtrate, moves through the tubular system, we are going to take back what we want to keep, for example, sodium and water. Similarly, we also have this system through here that lets us add in substances toward the distal end of the nephron to be added into the urine. So it helps keep what's in our blood balanced, allowing us to get rid of what we don't need and hold on to what we would like to keep. A couple more things to mention. This outer part of the kidney is called the renal cortex, the outer part. And then this more inner part here is called the medulla. And this again is where you'd find your nephrons. Going back to the glomerulus, I told you that when blood enters the glomerulus, substances within the blood are going to move into the capsular space, or that Bowman's capsule. Substances that are too large to move through the glomerulus to end up in this capsule are going to exit through this arteriole. What determines, though, the movement of substances here into the capsule? Well, hydrostatic pressure is a big one. Hydrostatic pressure being, in this case, the pressure exerted from the blood within the capillaries, has to be high enough to push blood from the glomerulus into the capsule. So hydrostatic pressure. Now moving on to talking about conditions that affect the urinary system, we're going to look at obstructions first. But to start, I'd like to inform you or remind you of the division that we have that's shown here by this imaginary line between the upper and the lower urinary tract. So if we talk about the upper urinary tract or an upper urinary tract condition, it's going to be one that is above the bladder. If we talk about a lower urinary tract condition, we're talking about conditions from the bladder down. So what is a urinary tract obstruction, also known as obstructive uropathy? It's any interference with the normal flow of urine at any site along the urinary tract. So if we know that urine's supposed to move from here in this direction, anything that is impeding that normal flow is considered an obstruction. And it can be an anatomical or a structural obstruction, or it can be a physiologic defect. So functional. Severity of an obstructive uropathy is determined by, one, the location of the obstructive lesion can determine how severe the obstruction is. The completeness of the obstruction, is it completely obstructing the normal flow of urine or just partially? Does it involve both ureters? Does it involve both kidneys? How long is the obstruction in effect? And what the cause is of the obstruction. Obstructions can be relieved or partially alleviated by correction of the obstruction, but permanent impairments can occur if you have a complete or partial obstruction that persists weeks to months or longer. Obstruction of the upper urinary tract causes what are referred to as dilations. Okay, think dilating, widening. We're going to talk about 3 different types of dilations when somebody has an obstruction: hydroureter hydronephrosis and ureterohydronephrosis. Starting with hydroureter. So hydro, think of fluid, and ureter, we know, is the structure, the tube that comes off of the kidney. So what we're talking about is some sort of obstruction, let's say here, that blocks the normal flow of urine. Let's zoom in and say here, an obstruction here. Let's say there's a stone in here. Urine should move in this direction, but if it can't move in the direction that it wants to, it's going to start to back up because we're still producing urine. It just has nowhere to go. And so it's going to cause it to dilate or widen. And the widening or the dilation occurs proximal to the obstruction, not distal, right? Proximal to the obstruction because the fluid builds up and starts to weaken those walls. So there's your actual definition. Hydronephrosis now. Let's clear my ink. Hydronephrosis is dilation of the renal pelvis and the calyces, which collectively we can call the renal collecting system. So let's look at this on the image. So hydronephrosis, renal pelvis, is all this area here. The calyces, remember we have minor and major calyces. This is the major calyce, okay? A major calyce here. These are the larger cups, and then we have the minor calyce, the smaller cups. So hydronephrosis then is widening of this entire system through here. And just as an example, you could have some sort of obstruction here that causes a backup of urine throughout this entire area. Next up is ureterohydronephrosis, which is really just a combination of these two. It's going to be dilation of the ureter and of the renal pelvis and calyces that are sometimes called the pelvic calyceal system. So what we're looking at then is, let's say there's an obstruction here that initially causes hydroureter, doesn't get treated, then it spreads because the urine continues to back up, causing widening or dilating of the structures proximal to that obstruction. So it's like it's spreading. That is, the dilation is spreading. And so when you have the renal pelvis and the collecting ducts that dilate, it causes swelling of the kidneys or of the affected kidney. Still on the topic of urinary tract obstructions, but now we're going to look at the different causes, and we're going to separate the causes into upper and lower urinary tract obstructions, remembering that imaginary line that sits just above the bladder. In starting with causes of upper urinary tract obstructions, we would be talking about obstructions relating to the kidneys and or the ureters. Urolithiasis is the most common cause. These are kidney stones, and the kidney stones are going to be made up of particular substances, either calcium salts, struvite, or uric acid. This, I would highly recommend you star. Calcium salts are the most common composition of urolithiasis. And even though you'll see this referred to as a kidney stone, it is really just a stone that is anywhere within the urinary tract. A lot of times they do form in the kidneys and then they will descend, but urolithiasis referring to stones in the urinary tract. So calcium stones are the most common. We'll see later that they can either be made out of oxalate, so calcium oxalate, or phosphate, calcium phosphate. Another cause is stenosis of the ureter. So here's your ureter, here's the ureter. This here is stenosis, which is a term that is used when we're describing narrowing, and the narrowing is usually caused by some sort of lesion that's present that narrows the lumen of the, in this case, the ureter. So that acts as an obstruction because urine can't easily move past that stenotic area. Stricture of the ureter. So here's a stricture, and you can see that these kind of look common. What's the difference? Well, a stricture you should make note of specifically refers to narrowing that's caused by contraction of the smooth muscle. So the ureter is made up of smooth muscle as one of its layers that encourage that one-way movement of urine. And if the smooth muscle contracts in an unusual fashion or in a way that it's not supposed to, it can be called a stricture, which narrows the lumen, making it difficult for urine to move past that point. And then a fibrous band is another example. Fibrous bands can form sometimes after somebody's had surgery. It's an abnormal connection between two structures. Sometimes you'll hear them referred to as adhesions that form between different tissues and different organs, kind of like an internal scar that connects tissues that are not normally supposed to be connected. Next up is our causes of lower urinary tract obstruction. So we're talking about the bladder and the urethra. Strictures and stenosis can also exist of the urethra itself. So this is where you could have narrowing of that lumen due to some sort of lesion that's present that narrows it, or smooth muscle contraction. Prostate enlargement. So this is referring to male anatomy, where here's the bladder, here's the prostate, and remember that the urethra runs through the prostate. So if the prostate's enlarged, it puts pressure on the urethra, which makes it difficult for urine to move past that obstruction. Pelvic organ prolapse can also be an issue, much more common in females, and in one organ only seen in females. Let's look at this here, in these three images. First, looking at normal. So this is a side view. We can think of this as a coronal cut. And what we can see is the vertebral column, sacrum, tailbone here. This is the gluteal area. We have the intestinal organs the uterus, the cervix, the vagina, and then anterior to that is the bladder and the urethra, and I should have said the rectum would be here, and then the anus, and then this is the pubic bone here, just to orient you. So under normal circumstances, the uterus lies at a bit of a right angle to the bladder, but in certain circumstances and more common post-pregnancies or after having children and also after menopause, some women can experience uterine prolapse, where the uterus descends because of weakness of surrounding structures, descends into the vagina. So that's what's happened here. This is a severe one, of course, but why does this add as an obstruction? Well, look what it's doing to the bladder. The bladder should be positioned like this and the urethra here. Now, the bladder and the urethra have been pulled in a downward direction, and this action has actually narrowed the lumen of the urethra. So that's an obstruction. And then a cystocele, this you can make note of is a bladder prolapse. So here again is the intestinal tract, the uterus, and the bladder. So this would be the urethra, the vagina, and the rectum. The bladder here, which should be positioned like this, has prolapsed through, really against the wall of the vagina. And what this does is it causes urine to pool in this area here. So it's more difficult for somebody that has a cystocele to bring the urine that's here up and out the urethra. So if you can picture here, it's just moving in this direction, not much effort's required, but now you have to bring it up and around. And that can be more challenging, and full emptying can be made very difficult. So this is somebody with this is also predisposed to a bladder infection as the fluid sits here and bacteria is more likely to proliferate. So let's look at the effects of hydronephrosis, remembering that hydronephrosis is enlargement of the renal pelvis and the calyces. Renal pelvis and the calyces, which would cause really that kidney to swell. I want you to picture this. Urine is really now going to be moving in an opposite direction. So what we have here is urine that should be moving in this direction, but because there is some sort of obstruction, it's backing up. It's continuing to back up. We're producing more of it. It's backing up, and it continues to back up right into the nephrons, right into the tubules. So it's backing up here. So this here is the renal, tip of the renal pyramid. So right here. So it's backing up in this direction into the tubule system. It backs up through these tubes here, in the wrong direction. And now it's entering Bowman's capsule. And now all of a sudden we have this increase in Bowman's capsule, and this is representing Bowman's capsule here and the glomerulus. Now we have this increase in pressure from the fluid in Bowman's capsule. Normally, the pressure within the capillary, that glomerulus, that capillary system, should be high enough to push urine into the capsule so that it can make its way through the tubular system. But now if it's backing up in the wrong direction, now it's a fighting or opposing pressure. So now we have this increase in fluid capacity within Bowman's capsule. An increase in fluid is going to lead to an increase in pressure. So this is a hydrostatic pressure, is a pressure from that fluid in Bowman's capsule. Now we have less of a difference between the pressure allowing blood to move this way and the pressure that's causing the fluid to move in the opposite direction. And so this means that that glomerulus is going to have a much harder time overcoming this opposing pressure. And so there's going to be a reduction in what we call glomerular filtration rate, which is just the rate at which we filter blood through and fluid through the glomerulus into the capsule in order to end up producing urine. And this then reduces the function of the kidney, renal referring to kidney. Still looking at urinary tract obstruction, upper specifically, we're going to look at the progression now. So we spoke already about how, let's say, some sort of obstruction, whatever it may be, a stricture or stenosis or urolithiasis, what this is going to do in the early phase is cause dilation. And we know that. We called that hydronephrosis. And the reason that the dilation occurs, as we've talked about already, is because of what's called urinary stasis, meaning urine builds up proximal to that obstruction, has nowhere else to go, but we keep producing urine, so it starts to dilate or widen and causing really the kidney to swell. After a week of this obstruction, assuming that it hasn't been removed, enlargement's going to be evident, as well as fibrosis. Enlargement and fibrosis. Enlargement's going to be because the smooth muscle that makes up many lines, many structures in our body is going to hypertrophy or get bigger. It's really an adaptation response. And some fibrosis can be evident. We don't like the term fibrosis. Fibrosis means that some permanent changes are occurring. Compensatory hypertrophy can occur if the obstruction is unilateral. Let me rephrase that and say that if somebody has an obstruction relating to one kidney, okay, so only let's say this one kidney here, but the other one is fine, then something called compensatory hypertrophy can occur. This is where the unobstructed or unaffected kidney can start to enlarge. And it enlarges to compensate for the other kidney, the affected kidney, not functioning as well as it should. So it's trying to do the job of both kidneys then. So the good kidney gets bigger to help out the bad kidney. The good thing about this, though, is if the obstruction is removed, this is reversible. So the unaffected kidney can return to its normal size. After 14 days, if the obstruction continues, this is where you're going to see effects at both distal and proximal aspects of the nephron. Remembering your nephrons are through here, so you're going to get effects at the bottom end and the top end of the nephron. It can back up to the point, as mentioned already, after about a month, where the glomerulus itself becomes damaged because the pressure is just far too high. We can start to see thinning of the renal cortex and medulla, so the outer and the inner part of the kidney, and this inability to properly regulate fluid and electrolyte levels and acid-base levels in our body. This is vital for survival. We need to be able to balance fluid and electrolyte levels. In other words, get rid of fluid and electrolytes that we don't need or hold on to fluid and electrolytes that we need, and our kidneys help control that, as well as acid-base balance. We know that the pH of our blood has to remain within a very narrow range in order for normal functions to occur. Removal of the obstruction within 56 to 69 days, and I won't ask you that specific number. This is where partial recovery of function can occur, but only partial. A person that has an obstruction that lasts this long will not have normal function, full function of their kidney. But that's okay, even with the only partial recovery, which can take upwards of 4 months, the kidney can still function properly or enough. There's a condition that's important for you to know called post-obstructive diuresis that needs to be considered when you're removing an obstruction. Let's break this down. Post means after. We know what obstruction means. So this is after the obstruction, diuresis, which is water loss. So let's go over here. When the obstruction is removed, it's almost like the kidney is trying to make up for lost time, because at this point there can be rapid excretion of large amounts of water, large amounts of electrolytes, Huge urine output, upwards of 10 liters per day, and you're looking at less than a liter per day is considered normal. So this person can end up in a state of severe dehydration with extensive loss of fluid and electrolyte levels, so big imbalance. So this needs to be considered and monitored anytime an obstruction is being removed, especially one that has been there for longer than a very short period. So that was progression of upper urinary tract obstructions. Let's now look at progression of lower urinary tract obstructions, remembering that that means from the bladder and below. So that was our imaginary line here. Here's a reminder of the different causes of a lower urinary tract obstruction. We're going to look at a state where someone has a chronic obstruction. Chronic obstruction, let's say prostate hypertrophy is our example here, prostate enlargement. If this is chronically enlarged, meaning that it is difficult and takes much more effort to push urine past that obstruction, it's going to lead to the increase in deposition of collagen within the bladder, so it starts to harden as a response. So that's a fibrotic response, and hypertrophy of the bladder. So the bladder here, the bladder muscle, is a smooth muscle called the detrusor muscle. And if it can't move urine normally, as normal past this obstruction, it's going to say, well, how can I get urine out of the bladder? Well, I'm going to get bigger. Hypertrophy. So it's adapting to its scenario. But hypertrophy or any form of cellular adaptation should really be a temporary thing because it can't fully function for long periods in this state. After a while, if it continues, we're going to start to see that the bladder wall becomes less compliant. The muscles become weak. So to rephrase that, when I talk about low bladder wall compliance and weak and smooth muscle, ultimately the bladder wall loses its ability to stretch and accommodate urine and contract efficiently. So we have reduced emptying. If we reduce how much urine is being emptied, it's going to cause the backup of urine because we're still producing urine, but we're not getting rid of all of it. So it backs up. And it can back up enough to cause hydroureter. It can back up enough to cause hydronephrosis or ureterohydronephrosis. One thing that's not shown on here, you could actually have a bladder stone that acts as an obstruction as well. Let's talk about these stones. These stones that can form, we primarily talk about them forming in the kidney, but they could in some cases form in the bladder. I told you that the majority are caused by calcium, but other examples include struvite and uric acid. The examples that I spoke to of the types of calcium stones are either calcium oxalate stones or calcium phosphate stones. Causes of stone formation include precipitation of salts from a liquid to a solid state. So if they become in their solid state, they're more likely to form stones. Supersaturation of one or more salts in the urine due to salt being present in a higher concentration than the volume able to dissolve it. So if we can't dissolve all of the salts, then they're more likely to be in their solid state and form a stone. Acidic versus basic pH. Those that have acidic urine are more likely to form stones from uric acid. Those that have more basic urine are more likely to form stones from calcium salts. And we know that calcium salts are a major cause. So we could say then, in a lot of cases where stones are formed, it is more likely that the pH of the urine is going to be basic. Absence of stone inhibitors. Our body naturally possesses these chemicals that inhibit stone formation, and so if we don't produce as much of these chemicals or there is none of them, then we can't prevent it from happening in the first place. Let's look at some of the clinical manifestations. Sometimes stone formation can be asymptomatic. Somebody can find out that they have a stone just by having an x-ray done for some other reason, and they notice that there is a stone that has formed, just as an example, and they never had any pain to indicate it. In other cases, they can cause what's called renal colic or flank pain. And in the cases where people have flank pain, that's usually because the stone is starting to move. And as it moves, it can damage the tissue in the area and cause hematuria, which is blood in the urine. Treatment includes higher fluid intake, trying to really dilute the stones and break them up, decreasing dietary intake of some stone-forming substances, which I'll talk about in a moment, and then stone removal in cases where it can't be broken up on its own. Kidney stones can vary in size and shape, and depending on the size of it, would determine if it's more likely to need to be removed rather than have you pass it on your own. And you can see the different shapes and sizes that they take on in every case. They don't look very enjoyable, that's for sure. Okay, so I just wanted to mention quickly about the food component, that there are certain foods, and it's not just bad foods. Like, even though meat and caffeine can lead to increased risk of stone formation, even something like spinach, which contains a lot of calcium oxalate. If you eat too much spinach, too much of a, just meaning that you can eat too much of a good thing. You think you're eating healthy by eating lots of spinach. If you eat too much, it can increase your chance of developing calcium oxalate stones, because there's just, you've really super saturated the calcium oxalate within your body. Moving on now to a different topic from obstructions, onto renal cancers or kidney cancers. There are two types of renal tumors that we're going to discuss today: Wilms tumor and renal cell carcinomas. Wilms tumor is considered an embryonal tumor of the kidney, so it's caused by abnormal proliferation of renal stem cells. It's also known as nephroblastoma, which is its histologic name. It is considered the most common solid tumor that's occurring in children. This tumor is cancerous, but what's interesting about this cancerous tumor compared to other cancerous tumors is it's very well defined. Normally, when we think of cancer, we think of poor defined borders. It also doesn't take away the function of the kidney for quite some time, so the kidney is still functional. But it needs to be what needs to be considered is that this tumor can metastasize and over time can change and spread. Moving on to renal cell carcinomas. These make up the majority of renal cell tumors, and they arise from epithelial cells, glandular epithelial cells, and that's where it gets the name adenocarcinoma. So carcinoma is cancer of epithelial cells, and adeno refers to glands. This cancer is unfortunate because the early stages are oftentimes silent, where only 10% are symptomatic in the earlier stages, with things such as blood in the urine, flank pain, and in some cases, if it's large enough and the person themselves isn't too big, there can be a palpable mass at the flank area, so the area where you would palpate the kidney. In majority of cases, though, it's considered subclinical, so there aren't any obvious signs or symptoms that would warrant any further testing. And in these cases, sometimes it can be misdiagnosed as being what we just spoke about, which is some sort of obstruction, also infection, which we'll talk about next. Or soon, I should say, because first we're going to look at bladder cancer. The most common cause of bladder cancer or bladder malignancy is called a urothelial carcinoma, also known as a transitional cell carcinoma. This would be if it is the primary tumor, meaning that it originates in the bladder. But you can also have bladder cancer that didn't originate there. It originated in common areas such as the cervix in females or the prostate in males, and then it spreads from these structures to the bladder. Bladder cancer is the 5th most common cancer. I wouldn't ask you that detail, but what I do want you to know is that it begins on the inner lining. So if we look at the bladder here, and here's the urethra, and here are the ureters. This is showing you the inner lining through here. So you can see that it begins on the inner lining rather than the middle or the outer lining. And then as it grows, it invades the other linings of the bladder. And of course, it's not moving along the bladder here. This is just showing you the transition or its development. Of important note here, if we look at cancer that develops here in the bladder, you could see why this would end up being an obstruction at some point with this ureter. Risk factors for bladder cancer include males that are over the age of 60, smoking, any inhaled carcinogens in general can be stored in the bladder and eventually the cells can change. Water chlorination, textile and rubber industries where they're using lots of different chemicals all contribute, but smoking is certainly a huge one. A consideration too with bladder cancer is that sometimes it can it can present as an infection, but it really is cancer. Now that's not to say if you have an infection, it could be cancer. It is more likely to be an infection than cancer, but the signs and symptoms in the early stages can be somewhat the same. But clinical manifestations that are common with specifically bladder cancer is a large amount of blood in the urine. And oftentimes it's painless, especially once it's progressed to the point where bleeding has occurred. And that can be the difference between an infection and cancer. But there can be some urinary tract symptoms that can be confused with a urinary tract infection, as we'll see coming up, including nocturia, which is excessive urination at night, urgency, so that sensation of needing to go. Even if you're not able to rid much urine, you still feel like you have to. And what's called urge urinary incontinence. So this is where there is no notice and leaking of urinary contents can occur before the person can get to the bathroom. Flank pain can also occur depending on how large the cancer is and if it's causing an obstruction. And I spoke about that just a moment ago, that if there's an obstruction at what's called the uretero-vesical junctions, this is the junction between the uterus and the bladder. So the vesical part is referring to bladder. So right here or right here can cause pain, but can also cause signs and symptoms higher up, as we spoke about dilations earlier. Now on to urinary tract infections, something that most people, especially women, will experience in their lifetime. This is inflammation of the urinary epithelial tissue caused by bacteria that got into the urinary tract, usually from the external environment. It's considered a retrograde infection because the bacteria actually move in this direction to infect. The most common offending pathogen is E. coli, and we'll talk about relevance of that soon. But what usually happens first is it starts as an infection in the urethra, causing urethritis. Inflammation is the itis part. And it does not take long for the bacteria to then travel to the bladder, causing inflammation of the bladder, which is called cystitis. And then this is usually where it's contained because the person will complain of the signs and symptoms of an infection pretty quickly once it hits the urethra and bladder. So it's usually under control, and then it takes a lot longer for the bacteria, although possible, to travel up in retrograde fashion, up the ureter to the kidney, where it can infect the kidney and cause inflammation, which is called pyelonephritis. So why does this happen? What are some of the factors that increase somebody's risk of developing a UTI? One is fecal contamination of the urethra due to poor hygiene around the anal and genital areas. I'm going to talk about this actually on the next slide because I have an image that shows that. So let me come back to that. Partial urinary tract obstruction. So for example, hypertrophy of the prostate. But if there's anything that's obstructing the normal flow of urine, it can actually pool in this area, the urine, and be predisposed. Remember, I talked about urinary stasis to bacterial proliferation. If somebody has a catheter, an indwelling catheter that's been left in for quite some time, it does introduce possible pathogens that can cause infection. Estrogen deficiency-induced epithelial atrophy. So with age and thinking maybe post-menopausal, there can be changes in that urinary tract epithelial tissue that predisposes it to bacterial proliferation. A neurogenic bladder. This is loss of bladder control due to either a brain, spinal cord, or nerve problem. And if you lose control of the bladder and you're not able to properly eliminate, it can predispose to infection. Urolithiasis, so if somebody has a bladder stone or even a kidney stone that causes some degree of obstruction and promotes urinary stasis, it can also predispose somebody. And then disruption of normal protective flora. This is a big one for females, but can also be a problem for males. Remember, throughout our body, on the surface of our skin and all throughout different areas and organs within our body, especially the bladder and digestive tract, we have this normal protective flora that exists. That it's this good bacteria that help ward off bad bacteria. But if you disrupt the normal protective flora, then the bad bacteria that normally wouldn't be able to proliferate can. How do we disrupt normal protective flora? Well, there are many ways, but a common way is the use of antibiotics. So antibiotics can be very beneficial when they're necessary, but whether they're necessary or not, they kill all bacteria, good bacteria throughout the body, and it can take time for the protective flora to continue to proliferate once again. Another example, which I'm now going to move on to the next slide and come back to this fecal contamination of the urethra due to poor hygiene as well. If we look at the proximity of the urethral opening to the vagina, what we can see is that if the vaginal area is cleaned too much, so using soap, or even on infants using certain wipes in this area that kill off the good bacteria, then it can predispose an infection to ensue in this area, which can travel to the bladder. But if we look at the fecal contamination component, the rectum and then the anus is in close proximity to the urethra in comparison to males. And so this is where women have to be very careful when it comes to E. coli that would be present in stool coming into contact with the urethra, where it can cause a bladder infection. And so this is where at a very young age, girls are taught to make sure that they're not wiping from back to front. And it's also an important consideration for hygiene of babies. So if somebody has a baby that is a female, proper hygiene is very important to prevent a bladder infection in that child. So as I've already alluded, women are more likely to have a UTI because their urethra is in closer proximity to the anal area, but also because it's shorter. For men, there's a longer pathway that the bacteria have to travel to get to the bladder. And so oftentimes they'll be working their way, trying to get to the bladder, and then the male will urinate before they get there, which helps clear up that bacteria. Clinical manifestations, frequency, having to constantly go to the bathroom, but also feeling that it is urgent in nature. Dysuria refers to painful urination. That's a big one, and that's usually what brings somebody to see their doctor. And then lower abdominal and or suprapubic pain. So let's look at this. This is a big one for helping to diagnose a bladder infection even before a test is done on the person's urine. Here's the pubic bone. So we're looking at female right now. If you have this patient lie down on their back, so they're lying supine, and you have them relax their abdomen as much as they can, and you apply pressure suprapubically above the pubic bone, you will come into contact with the bladder. And in somebody that has a bladder infection or cystitis, this is going to be extremely painful, and they will probably guard right away and tighten up their abdomen and not want you to put pressure there. Treatment includes specific antibacterial therapy or antibiotics, I should say, an increase in fluid intake, avoidance of foods and drinks that are known to irritate the bladder, and then oftentimes urinary analgesics will have to be taken. So these are pain medications that will make their way to the bladder, so the kidney will clear it, it'll make its way to the bladder, and it kind of coats the bladder and offers some pain relief. Still on the topic of infection, remembering that cystitis refers to inflammation due to infection of the bladder, and pyelonephritis is referring to the kidney. Cystitis can range, if we look at the kidney or the bladder tissue itself, from just being inflamed, where it would be considered mild, to more severe cases where ulcering is evident and even evidence of tissue death. Acute nephritis is the most common that you'll see. It's the most common type of urinary tract infection, and it's oftentimes without complications. So the person will be in enough pain with urination that they will present to their doctor and within a couple of days feel significantly better, assuming that they're on the correct antibiotic. What will happen in most cases is the patient will urinate in a cup. So they give a urine sample, it's tested and positive for an infection, and they'll be given an antibiotic for the most likely bacteria. However, the urine will then be sent to a lab where they'll culture it, and they can determine exactly what grew and how it responds to antibiotics. And if the person does not respond to the antibiotic then they were given, it could be because they were given the wrong one. But in any case, it's usually without any complications. But in more serious cases, if you have cystitis that isn't treated quick enough or isn't treated successfully, it can migrate upwards to the kidney and cause pyelonephritis. In most cases, that's how it gets there. It goes there from the bladder, up the ureters to the kidney. In some cases, somebody could have a infection that gets into the blood, so bacteremia, and that is a method of it getting to the kidney and infecting the kidney in some cases. In other cases, we can have two different forms of pyelonephritis, acute and chronic, that are not necessarily from or related to an initial infection of the bladder. Acute pyelonephritis most times occurs because there's some urinary tract obstruction. So an obstruction somewhere that causes urinary stasis, where the kidney can become inflamed because pathogens can procreate. Those that are pregnant are predisposed to acute pyelonephritis, a neurogenic bladder if you can't empty a bladder fully, and instrumentation use can also introduce bacteria. Chronic pyelonephritis is where there is this persistent, reoccurring episodes of the acute pyelonephritis. But when it becomes chronic, it means fibrosis can occur or scarring, and this is where permanent destruction of kidney structures can occur, leading to impaired function and possible renal failure. That's the end of this lecture. Thanks for your time. Bye for now.